So the purpose of this is that I want to get blades and meds in hands, right? So we RSI as a whole team less than 20 times per year. And I want us to each have more practice under our belts so that it feels better. So the way the situation works is that you're going to get a pre-arrival at the beginning of the month to show you the scenario for the month so you can, practice and have good reps under your belt, but be familiar with something that you're going to do. And then we're sending out this video this one time so you can see what it looks like from, if you're a third party observer. You're going to work with a partner like you would on a call. You're never on a call by yourself. So you'll have a partner. It could be a nurse call. It could be like an echo call with another paramedic. And although we don't traditionally do that, that is a possibility. And, or it could be a nurse medic call like we do most of the time, but you'll always have a partner. One of you will do meds, one of you will do airway, and then you'll repeat and switch so you can both be signed off on both components of meds and airway. This particular month only, we're doing ultra low dose epi in the scenario, specifically to check everybody off on doing ultra low dose epi before we introduce it to the drug bag. You may see that in a future month as a presser, but there's not going to be a specific sign off in a future month. So I'll just sign off at the end of the scenario that you did the math, the volume correctly, and that you can draw a med up with proper mechanics. Okay. So do you guys have any questions before we start? You have all the drugs in this drug bag. You have an intubation setup with the tubes and the blades over there. This is a infant head, I would say. Towel roll, suction, some pointers of things that make a successful intubation scenario, pre and post intubation checklists, tape your tube like you would normally. You can assume that your patient is stable unless I specifically state that a vital sign is deteriorating, and then you can ask for a reassessment for it to come back up. But it's not going to evolve into like a cardiac arrest scenario or anything where you would give arrest meds currently. You might need to support a blood pressure or a pulse ox, but don't expect to do compressions at any point. You're not getting burged. What else? You should expect that your equipment would work normally. So you should have lights on your blades. If you don't, you can ask to stop the scenario, fix that, and start over, or pause and resume. You should have correct volume of drug in your drugs. We've tried to replicate drugs as close as we can to what's in the actual drug bag. You can also expect to have answers to all your questions. So for example, this month there's an available chest x-ray. I've printed it out for you and you can see it. You can write on these pre-arrivals. All of that's okay. Also, I want to emphasize that this is about learning and I want you to feel not pressured. So the patient won't die. There's no scoring for the first little bit, at least. So while you can make a mental note, maybe write down some notes in your phone of how you did, we're going to debrief certainly so we can all learn. But I'm not going to say you got an A or a B, you got a 90% or 40%. Frankly, I want you to develop your own practice. I'm going to give you pointers on your own practice and technique. But I want you to feel that from now until 6 months from now, you've made some sort of progress. But for this first little bit while we're doing this, you're going to be your own gauge of that. Okay, so these are the pre-arrivals. You guys each have a pre-arrival on the table, so we're going to read through it together. I'll read out loud. So this is Sally Snugglebug. She is 9 months old, 8 kilograms. She is a P2 Charlie Air going to the PICU. Dr. Quinn was your MCO on the original call with the intake nurse. This patient is previously healthy, up to date on vaccinations, presents with 4 days of fever, decreased PO, lethargy, there's a concern for sepsis, has a right otitis media, left lower lobe pneumonia on chest x-ray. The outside hospital did give antibiotics. The patient was initially tachypnic, tachy, and looking a little dehydrated on arrival. The patient's had poor PO intake for the last 24 hours. The patient remained tachycardic after 2 fluid boluses, so that's a total of 40 cc's per kilogram, and is showing signs of continued poor perfusion with concern for bacteremia. There were blood cultures, CBC, and BMP obtained, and the patient was given an initial dose of ceftriaxone, 50 per kilo, and was also given 15 per kilo of Tylenol PR. Current vital signs, heart rate 190, respiratory rate 60, the temp is 103, and the patient's 92%, and the BP has not been obtained. Okay, and then you guys can pre-plan like you would normally. You land and arrive. So when you walk in the room, you see a lethargic, minimally responsive baby. That's to both you and the parents. So the baby is tachypnic and grunting. When you approach the baby, they look mottled. You feel pulses, and they're weak peripherally, central or 2+. Cap refill is 4 to 5 seconds. You hear crackles in the left lower lobes. All other fields are clear to auscultation. Yep, this is the chest x-ray. They got ceftriaxone 50 per kilo. You also notice on the bedside monitor the patient's 88%, but is on a 10-liter non-rebreather mask. And does have double IV access, though. Nurse reports no wet diapers for 6 hours. And mom says the last wet diaper was 4 hours prior to them coming to the ED. So I'm going to say that Josh and Danny are subsequently also going to contact the outside hospital physician. And when they have the opportunity, they're going to call the MCO to confirm their orders. Sure. So I would recommend also atropine, just prepping a dose. Okay, so we're going to do atropine is 0.02 milligrams per kilogram, fentanyl 2 mics per kilo, Versed, let's do 0.1 milligrams per kilogram, and rock 1 per kilo. And then I'm okay with your additional 20 per kilo bolus. And if you need to start epinephrine for MAPS less than 60, let's start at 0.05. Ultra low dose, we're going to do 1 mic per kilo, and the baby's 8. Sweet, I hear that. All right, Dana, please call back if you need anything, and call back after you intubate, and we can discuss titrating vent settings.
For confirmation, 2 per kilo of fentanyl.
Yep.
0.1 per kilo of Versed, 1 per kilo of rock, and 1 mic per kilo.
Yes.
Of epi.
Yep.
All right.
All right.
All right.
All right. So do you want to read off the timeout checklist?
Yes. All right. So timeout. Everyone's agreeing with intubation.
Yes.
We have suction set up.
Section.
Reoxygenating.
Yep.
NP or OPA is needed.
Yep. I have a OPA here that's properly sized for the patient.
All right. Equipment check. Our laryngoscope.
Check.
ET tube.
Yep.
Stylet.
I do.
Syringe if cuffed.
For the purpose of this demonstration, we're using a 3.0 uncuffed, but we want you to properly size your endotracheal tube for the patient using the same size and a half size smaller of either a cuffed or uncuffed tube.
BVM and PEEP valve.
Check and check.
Backup LMA.
I do. I have it right here.
Perfect. Tape.
Tape is already here and pre-cut.
All right. Position of patient is optimized.
Yes. The table's a little bit low, so if I were in real life, I'd want the bed to come up a little bit, but I'm okay with this position.
All right. No C-collar. Meds ready.
Yep. So let's go through your meds. Let's just do our double check there real quick.
All right. So first one is fentanyl.
Fentanyl, 0.32, 16 mics.
This one's Versed.
Versed, 0.8 mics, 0.8 mLs.
Rocuronium.
Rock, 8 milligrams, 0.8 mLs.
And I'll double check your ultra low dose epi. Cool.
All right.
All right.
Checklist complete.
Flush our IV.
Yep, you got all that?
Cool.
So Josh, if you want to go ahead with meds, fentanyl first.
All right. Starting with fentanyl.
We want end title on our... We'd ask the outside hospital to start recording.
Flushing between each man. Next is Versed. 0.8 milligrams. We'll do like 30 seconds to a minute to try and avoid hypotension.
And recycling a blood pressure cuff every 2 minutes.
All right. Let me know when you're ready for the rock.
Yep, go ahead.
All right. Rock's going to be 8 milligrams. Flush after the rock.
Wait about 30 to 45 seconds before testing for unresponsiveness and effective muscle relaxation. I'm able to bag easily. And good sats and end title. Yeah, so when I get in there, if I need section or something, you might hand that to me.
Will do.
Cool. All right, so it's been about 45 seconds. Check if the baby's unresponsive. Lifting arms, they're flaccid, so we're going to proceed. All right, so I see the epiglottis. I can see the vocal cords tube. All right, and I am through the cords at the second black line.
I got the stylet.
Thank you. I'm just going to confirm. All right, and do we have good end title?
Good end title reading.
And Josh, can you listen to both flowing bilateral breath sounds?
Absolutely. On the right, on the left, and absent in the stomach.
Okay, awesome. So then we'll just have the outside hospital RT take over bagging while we go ahead and proceed with taping. We want to prep the cheek pads. We want to put Duoderm down. And then we can start by putting on tape.
All right, ready for post-intubation checklist?
Yep.
All right, chest X-ray if time permits.
Yep.
We have the tube secured, confirmed depth.
Tube is secure.
For our continuous sedation plan.
Yeah. We can do continued fentanyl pushes here until we can get them back to children's.
OG, NG if needed.
I do have an NG right here, so let me just put that down before we go for x-ray.
Right, and restraints if needed.
I don't think we'll need. We can just bundle them up.
Right.
The baby's pretty small.
Blood pressure still good?
Looks like blood pressure is a little bit low, so let's go ahead and get that epi going.
Okay.
Go ahead and push that, and then we can start an epi. Let's get an epi drip prepared.
All right. It's going to be 8 mics of ultra low dose epi.
Okay. That should give us probably about 2 to 5 minutes of kind of blood pressure support while we wait for the epi drip.
So I think in real life, the big difference would be that you have a pulse ox running, and that would kind of delegate back to you how long you can stay in the mouth, right? So if your pulse ox is good,
I would stay in the mouth unless my SATs were to drop. This kid started at 93, so if the SATs were to drop to like 85, I'd probably abort the attempt.
it's a good marker. 85 is a great marker. So I think that you would come out of the mouth, bag back up, and then try again. And then we get 2 attempts, and then we seek higher level of experience, care, what have you. I think the meds were good. You guys talked calmly through the whole thing. I noticed that neither of you got ramped up, which felt really good to me. If I had been an outside hospital provider, I would have been concerned because we're intubating, but I wouldn't have been extra ramped up by your emotions. That felt good. And I would challenge people that this is the opportunity to do the things. So if you haven't touched the CMAC in 6 months, let's pull out the CMAC. If you use Max exclusively and you want to practice on a Miller, let's do that. Like, this is the opportunity to play around with things that aren't in your traditional bailiwick. Cool.